I'd like to welcome you to Conference from Your Couch. I'm Kelly with the National Foundation for Ectodermal Dysplasias, and I'll be moderating our webinar this evening. We have also with us Dr. Brandon Hopkins, and he is going to lead our webinar on ear, nose, and throat concerns that are related to the ectodermal dysplasia. So thank you, Dr. Hopkins, for being with us this evening. I'll share with you just a little bit about Dr. Hopkins, and then we'll also go through some rules for this evening, just what I like to call our housekeeping. All right. Dr. Hopkins is currently the section head of the pediatric otolaryngology department at the Cleveland Clinic, and you've been there for about 6 years, I think, or nearly 7 years, I think you shared with me. And he also does some wonderful work outside of our country with the cleft lip and palate teams, and I'm going to let him share that with you. But he's served with us for 2 years, or nearly 2 years, on the NFED Scientific Advisory Council, and we're thrilled to have him on board with us. He was probably answering some questions and helping out prior to when his term officially started, I have no doubt. So we welcome you this evening, and would you like to share just a little bit more about your tenure at the Cleveland Clinic and some of the other work that you do?
Sure, guys. It's a pleasure to be here today. Like Kelly mentioned, I'm a 6-year veteran of the Cleveland Clinic. I've been a pediatric otolaryngologist there during that time. I trained out at UC Davis in California, and before that, my time was spent in Cincinnati for residency training. Outside of the InFed Foundation, I also work with a group called Faces of Tomorrow, which is a nonprofit that does cleft lip and palate work overseas, and I've been with them for 8 or 10 years now. They're a really great group as well if you want to check them out. But it is my absolute pleasure to be with you guys here today. And I also want to thank Raj Sinwani, who was kind of my predecessor on this group and still actively involved, but he's been a great mentor in this role as well. So thank you guys, and hopefully I will live up to his previous great role model.
I'm sure you will. I'm sure you will. Thank you for giving us your time this evening. We have always had, since I've been with the foundation, an awesome scientific advisory council and board of directors. Everyone is always so giving of their time and talents and expertise. And as you know, for a population that's considered rare, that's very valuable. So we all thank you, the staff, and I know our families. So just a few helpful tips for tonight's webinar. Tonight's webinar is being recorded. We have everyone except for the 2 of us will be muted. You have an option to ask questions at the end of the presentation, and you can put those into the chat box or the Q&A function. We'll address those individually. Should we run out of time, we will answer them throughout the next week or so. Email Dr. Hopkins questions with him, and he provide me with answers, and then I will send them on to you. So the recording will be later saved to the NFED YouTube channel, and we will also email it to anyone that registered for the webinar tonight. So get your pad and paper out, or your iPad, whatever it is that you use. I am old school and do everything by notebook. And so start taking notes. And if you have any questions or follow-up questions, my email is there on the slide currently. It's kelley@nfed.org, and you can send them to me and we'll certainly get them addressed. All right, I'm going to stop sharing my screen so that Dr. Hopkins can pick up on his side and tell us a little bit about the ear, nose, and throat.
Thank you, Kelly. Let's see.
Perfect.
Are we live? Can you see my screen?
I can, yes.
Awesome. So guys, again, thank you very much. It's been a couple years since there's been a webinar on ENT manifestations. You'll probably get a little flavor difference than you had last time from Dr. Sinwani. He's actually a rhinologist, so a sinus surgeon. So I can't do the same justice he can do with the nose, but I'm a pediatric ENT guy, so you'll probably get a little bit more of the P perspective for me, and hopefully with those two, we can be good point people for questions that you may have along the way. What we'll start out with is kind of a couple different areas. We're going to cover ear and hearing manifestations, airway and sinonasal manifestations, and oral cavity and throat manifestations of ectodermal dysplasia. It's a little mnemonic to keep me honest throughout the day. So when I was kind of reading and learning about this over the last couple of years, it took me a little while to kind of wrap my mind around why all these different issues happen. So I wanted to take a step back for you guys and let you kind of see the way I think about this. When babies are being formed from just a solid hunk of tissue as an embryo, there's a lot of different things that have to happen to make things go right. There's a couple different types of tissue that all form in the head and neck from these pharyngeal and branchial arches. And this is way too complicated for me to look at and understand. I'm a kind of country boy from East Tennessee. So the way I like to think of this is a bunch of hamburger patties on a plate. This is the future head and neck of your beautiful son or child. And all these tissues have to be smashed together and come together just right, or things don't go along the normal anatomical pathways. And you have a couple different areas that are to think about. One is ectoderm, and that's what's affected by ectodermal dysplasia. That's on the outside of these pieces of tissue that have to fuse together. Mesoderm is the kind of bulk of the tissue, and the inside, what you would consider the inside of your mouth, the inside of your aerodigestive tract, your esophagus, and your airway, is endoderm. So ectoderm, mesoderm, and endoderm. And you can see in between these pieces of meat, there's little folds or clefts and pouches. And like the first one at the very top of this picture ends up being your ear canal. That's the first pharyngeal cleft, or the branchial cleft. And this is why it all makes sense, is because they come from a very expected kind of origin from this ectoderm. So we'll start with ear and hearing manifestations. And you can have external ear anomalies, ear canal patency and narrowing issues. As you all well know, cerumen impaction can be an issue, hearing loss, recurrent ear infections, and hearing amplification, I think, wasn't covered as much in the last webinar, but I think we're going to cover that a little bit better today. So the external ear comes back to that same developmental structure. What you're looking at right here is the first pharyngeal cleft. And this is that ectoderm that has to come together and fuse and make your external ear. If that ectoderm doesn't come together well, you get some of the classic external ear manifestations of ectodermal dysplasia. You're lacking the antihelical fold, that kind of distinctive fold of the back of the ear, and it's a little less well-defined. Shin and Hartnick in 2004 found at least 27% of patients with ectodermal dysplasia at the two patient family conferences had these very distinctive ear features. You also have ear canal narrowing, ear wax impaction, but a lot of this wax impaction is also due to keratin debris. So because the mucus glands are not as prominent or not as active, there can be dryness and skin sloughing and skin shedding that mixes with that wax. It can create a really just firm and hard plug that can require some issues. And the study in 2007 by Meta found that this cerumen impaction and these ear issues can be one of the largest quality of life impactors for patients with ectodermal dysplasia. So we'll talk about my thoughts on kind of managing that as well. Conchoidal irritation, this can be just the opening of the ear canal can become very inflamed and irritated, very much due to dryness and skin breakdown. The same as if I, in the hospital now with the COVID pandemic, I probably wash my hands 5,000 times a day. So by the end of the day, my hands are dry and cracked and I have to put some lotion on them. And that's same kind of thought process can be used for the ear canal as well. And this can lead to otitis externa, that breakdown of the skin, as you can see here on that picture. In that ear canal, the barrier from the skin, if it breaks down, it can predispose you to getting infected with bacteria, and that can manifest with what's classic swimmer's ear and ear drainage and pain when you pull on that external ear canal. And that needs to be treated with debridement, and a lot of times the doctor will also prescribe antibiotic drops that can be placed in that ear canal. So this is earwax and cerumen removal is really one of the main hot topics with ectodermal dysplasia because it can be persistent and recurrent issues. Now, in my world, I think that the take-home message you're going to find today is identifying good partners to work with from your medical team. In my practice and most ENT's practice, we're going to remove this wax impaction with a direct microscope or special loupes and special glasses to remove this wax. Irrigations can be helpful, but you just have to be careful who's doing them and are they well trained and comfortable removing that wax. Because irrigation is kind of a blind technique and you have to be gentle not to damage something. Sometimes your primary care physicians can manage that, but again, a lot of times that's going to fall on the shoulders of your primary otolaryngologist. Half-strength vinegar drops, there's over-the-counter Vosol. Vosol is a kind of common medication that can loosen wax up and kind of dissolve some of it. If it's a very impacted wax and keratin plug, that's not going to remove it completely, but it may facilitate an easier removal by a specialist. So a lot of times when people come to my office, or especially children, and they're really not amenable to being under a microscope for an extended period of time, we can use these drops to loosen that wax and bring them back in a second visit, and makes it much more comfortable to remove that wax impaction. Mineral oil drops are actually my most kind of common prescription for somebody who has a dry ear canal, who is prone to sloughing of skin and keratin debris. It's very similar again to how when I wash my hands and they get dry and I need to use lotion. I do want to warn, much like every ENT shouts from the rafters, that Q-tips can be troublesome for patients, and I think ectodermal dysplasia patients are even more so with this, because the likelihood of impacting that wax down into a firm plug can be an issue. And I think it's also important to keep in mind that wax is supposed to be there. Wax is an antibacterial and it's a lubricating substance, so you don't have to remove wax unless it causes hearing loss. And the only time it causes hearing loss is when it is packed in like a firm, hard plug. And again, the key is to partner with an ENT to make sure that your ear canal is patent, and when you have issues, you have somebody to bounce ideas off of. So now that's the external ear and the ear canal, but that's only a very small part of hearing. The other part of hearing is your inner ear, and that inner ear forms from the otic plateau, which, lo and behold, it is also ectodermal tissue. So it's not surprising that there could be some issues with the inner ear in patients with ectodermal dysplasia. Now, that otic plateau has to invaginate and form and bend and turn and become the inner ear. This inner ear is a pretty, intricate structure, and along the way, if it doesn't form just right, you can have sensory neural hearing loss. We got a question the other day about, do patients with ectodermal dysplasia also have higher rates of positional vertigo or benign positional vertigo, which would be a direct result of a malformation or an anomaly with this structure you're seeing here on the right, which is the inner ear. And I think the answer is we just don't know. There's not enough literature or information out there of whether the rates of vertigo are higher in ectodermal dysplasia patients or not. And that's maybe something you guys can answer even better than me. But if that is the case, then clearly an ENT would be the place to start with that. But I think it's interesting that we don't know what the rate of nerve or hearing loss is in this population, when clearly we've identified that hearing loss impacts ectodermal dysplasia patients. The studies that have been done at the patient family conferences show that patients have hearing issues, they have difficulty paying attention. So this is something that clearly needs to be high on your priority list, especially early in life for patients. And you may ask why. I think that it's very important to identify this hearing loss in all children, but especially children that may be at risk for other issues. They can have difficulty with attention, learning, and social function. They do less well on standardized tests if you can't hear. They have a higher risk of repeating grades, language and reading achievements, sound localization. And interestingly, there's a direct link to hearing disabilities at young ages and earning potential later in life. So something very important to kind of identify. And when I think of hearing loss, there's two different ways to break it down. One is timing and one is type, and we'll go through both of those. First is timing, congenital. Are you born with this hearing loss, or does it acquire later in life? Congenital or hearing loss you're born with is either due to something that happened during the pregnancy, a virus or something that a mother caught during pregnancy, or it's genetic. It's something that is passed down because of a chromosomal abnormality. Now, the link between hearing loss and ectodermal dysplasia has been mentioned, but again, I don't know if we have a direct cause for that, even though the embryology makes very good sense. It's ectodermal origin, and that's what makes the inner ear. So there's probably something there that we just don't know yet. So there definitely is some genetic link. We just aren't sure exactly what that is. Acquired hearing loss, though, makes perfect sense for ectodermal dysplasia. We have earwax impaction, we have middle ear infections and effusions. Noise exposure is really not one of them. Head injury, medications, or infections. These are other things that you can get hearing loss after you're born. Now, the two types are nerve hearing loss, that snail shell we talked about, and conductive hearing loss. And the reason that matters is because the ear is a transducer. It takes sound from the outside world, sound comes in, hits the eardrum, amplifies sounds by those little vibrating ear bones, and then changes sound energy into mechanical energy and then electricity that goes to your brain. So it changes one form of energy to the other. Along the way, there can be problems with that. If that transmission of sound isn't perfect, you get the green box, which is conductive hearing loss. It's where you sound muffled, whether that's due to wax or whether that's due to something plugging up your ear. The purple box is sensory neural hearing loss. That's hearing loss where the cochlea is not sending the signal to the brain. Sensory neural hearing loss is typically not correctable. It's addressable and aidable, but it typically can't be fixed once it happens. The conductive hearing losses can be several, like we talked about, earwax blocking the eardrum, so it muffles that sound, fluid behind an ear, or a hole in the eardrum, or ear canal stenosis can cause this issue as well, just the transmission of sound. This is what a normal drum would look like when I look at it in my office. I can see it, it's translucent, it vibrates when I puff on it. Now, if a child comes into me with an ear infection, this is what an ear infection looks like. That drum is bulging, there's fluid behind it. It's just an angry looking mad drum. And these children can't hear very well at that acute time. But even after I treat this with antibiotics and the infection goes away, a lot of times what we're left with is otitis media with effusion. And this is even more prominent in any patients with eustachian tube dysfunction. And because the cilia in patients with external dysplasia do not work as well, eustachian tube dysfunction rates are high. We don't know exactly how high, but it seems to be higher than general population. So this predisposes patients to this fluid behind this eardrum. Most of us have probably felt that if we've had a cold or if we went up on a plane and we couldn't pop our ears and it felt like we were muffled and underwater. That sensation when you go on a mountain or a plane and pop your ears, that's your eustachian tube popping open your eardrums so air and or fluid doesn't build up behind there. If that fluid builds up, you're underwater and muffled and can't hear. Again, this is another picture of that. The treatment for that typically, if it lasts more than 3 months in my world, is to place an ear tube to facilitate hearing, because I can vacuum that fluid out just like this picture. You can see here where we're making an incision in the eardrum, vacuuming out some fluid. And this fluid's pretty murky, so this is, it looks like there's some inflammation, infection. And you can see it's vacuum that fluid out of that small little hole in the eardrum, done under a microscope with a little bit of mask anesthesia. And then we'll place a small little plastic tube in that little middle ear hole, and we'll pop that tube in place. Now, these ear tubes that many children with ectodermal dysplasia and some adults get typically last about 12 to 18 months. We make longer tubes that last longer, but typically this is what we start out with for most patients, because the natural progression in the general population is for eustachian tube function to get better. I don't know what the progression of this is in the population with ectodermal dysplasia. We just don't have that information. So now that we've identified that hearing is important, and we've identified the types of hearing loss and kind of the mechanics behind that, what should we be doing? And I would say we should at least be doing the same thing as the American Academy of Pediatrics recommends, and that's universal newborn hearing screen. So every newborn baby gets this before they leave the hospital. And if you've had a home birth, it should happen within 3 months. Preschool children should get screening every year. School-age children get screening at kindergarten, 1st, 3rd, and 5th grade. And every year you go to a pediatrician's office, they should be screening you for hearing loss. If at any of these times you fail that newborn hearing screen or fail one of these screens, you need a formal evaluation and a referral for a formal hearing testing and a middle ear evaluation to see if there's fluid or wax impaction or if there's a nerve hearing loss. So like we said, there can be multiple types of hearing loss, and it requires kind of subspecialty or specialty expertise to identify, is it correctable or is it not correctable? And we'll talk about how to treat it if it's not correctable. Ectodermal dysplasia is a little different though. We don't know how often to check outside of those standard screening times. In my mind, I think I would put this population in a higher risk category, much like a cleft palate population, or much like a population who has learning disabilities or is predisposed and at risk. Maybe prematurity would be in that same population. But I think every 6 months after age 1.5 or 2, a formal hearing test is a very reasonable thing to do to make sure these patients don't slip through the cracks. That requires good partnership with your pediatrician and ENT and your teachers, because teachers are going to be the people who identify these problems early on. And be on the lookout for hearing concerns. If you think there's a hearing concern, it may just be that they're turning the volume on the TV up. They're asking to repeat questions. They're saying what? They get tired when they're listening because they're having to concentrate a whole lot. Inappropriate answers, you may ask one thing and they say something different. They're isolated from peers because they don't have that energy to really participate in conversations. Difficulty reading skills, easily frustrated, or has difficulty with spoken or written language. It's really hard to expect somebody to have normal speech if they're not hearing normal. And I like to say, like, a good rule of thumb is if by age 2 you can't say 20 words and start putting 1 to 2 word sentences together with kind of a 50-word vocabulary, you're probably at risk and you need a formal hearing evaluation. And any time there's hearing loss that's identified that's not correctable, you need to work with the school systems to make sure there is a individualized learning plan for your child and that hearing is on that. That way they can be appropriate seating in the classroom and they can have more time for testing, whatever that means for that particular student. What can we do? For adults and children, we have very low profile hearing aids, but I think these can be difficult with patients with ectodermal dysplasia or any ear canal stenosis issues because you have to have a patent ear canal for that to function well. So we do have other options as well. We have bone conduction hearing aids that can send that sound directly from the bone behind your ear directly to that cochlea. It bypasses your ear canal and bypasses those bones. And there's multiple different types of these devices. The one you're looking at here is an implantable device, but they also have ones that are just headphones, much like the headphones I'm wearing on my ears right now. They vibrate against your skull and send that information directly into your ear. For patients who have deafness or profound or really high levels of nerve hearing loss, that cochlea is not working well, just turning sound up doesn't help. That's when something like a cochlear implant may be beneficial, and that's where working with an ENT and an audiologist can tell you which type of hearing aid would be best for your family member. So we're going to switch gears a little bit, and we're going to move away from ears and move to airway and sinonasal concerns. And when I'm thinking about this, I go back to the origin of ectoderm and what comes from that. And I think that some of the derivatives of that are the serous, the mucus glands, and also the cilia that are present in the upper aerodigestive tract. The mucus glands, if they're not there, things are dry. If cilia aren't there, cilia are those magic little tendrils that kind of push things out and push things where they're not supposed to be. So they push things up from your lung and you cough them and swallow that spit, or you push things out of your sinuses and you blow your nose. If those aren't present, you are predisposed to having issues in your nose, issues in your eustachian tube, and possibly issues in your trachea and lungs as well. The actual effect on your sense of smell really isn't known, so I think that's a question mark out there in the world. But the same type processes can be seen with other diseases, where primary ciliary dyskinesia This is a process that doesn't have cilia that work well, and cystic fibrosis also doesn't have the ability to clear those secretions because they become thick and tenacious. So a lot of the same things that work for these other disease processes can be implemented for ectodermal dysplasia, and a lot of that comes down to clearance of secretions and pulmonary toilet. So speaking of pulmonary toilet, what are the respiratory issues that patients can have? You can get recurrent airway infections early in life. Increased rates of asthma and difficulty breathing has been shown by previous people looking. Recurrent pneumonias can be found when you're young in life. But I think the question is, what do we do about this? Because you can't fix that underlying cilia. You can't fix that underlying dryness itself. So it's what things can we do to manage that problem? And some of the best things to do are chest physiotherapy. So partnering with a pulmonary doctor for the lungs, percussions, there's things we can do with vest therapy to kind of help mobilize those secretions. There are aerosolizations where patients can do to loosen secretions up in their lungs. There's a treatment called hypersaline, which inhaled, it's just lots more water into the lungs, and it can loosen those secretions a lot of times in concert with percussions. And those are things that our pulmonary team is very comfortable doing with patients with cystic fibrosis and primary ciliary dyskinesia. I think that we just don't see enough patients with ectodermal dysplasia, but when you go to see a pulmonologist, I think letting them know that this disease process can be similar will help guide them in terms of what to do and how to treat your family members. So back to my world a little bit, sinonasal manifestations. I think you guys are all very well of the distinctive nasal shape that can be common, sinusitis, allergic rhinitis, nasal crusting, and epistaxis. And with nasal crusting being, I think, what in the past people have found as one of the biggest quality of life impactors, and we'll talk about what we can do to manage that, or at least treat that once you identify it. The saddle nose deformity, we don't know why that happens. It's been postulated that it's the blood supply to the nasal bones during growth that kind of impacts these nasal bones and you lose nasal support. The question is when to address that and if you should address that. I think the biggest question is, what is your goal? Is it a functional goal in terms of moving air through your nose, and is it a cosmetic goal? So I think they can both align, but you have to know what you're treating. And when an ENT can look in the nose and tell you if this is with a camera and sometimes just a nasal scope by looking, and they can tell you if this saddle nose deformity is causing nasal obstruction. If it was to be corrected, I think most of the time that we're going to address these at full growth. At full growth for a male, a nose is full grown sometime between 16 and 18 years. And for a female, that's somewhere around 14 to 17 years. So in my practice, it's when your nose is the same size as your dad's nose or your mom's nose, it's probably okay to start thinking about addressing this. If this was to be addressed, a lot of times this requires, in a young child, a rib harvest in terms of using that cartilage for rib to rebuild the nasal dorsum of the nose. And that's actually tolerated very well, even though it sounds a little brutal in all honesty. Rhinosinusitis, this is clearly an issue with patients with ectodermal dysplasia. It makes a lot of sense. If you can't clear secretions out of your nose and you can't mobilize particles and bacteria or viruses, you're going to be prone to catch more things. So antibiotic use is common in this population, and sinus surgery is much more common than the general population. And this study was found to be about 18%. So what does that look like? For adults, I think the symptoms are very similar to a general population, where you get nasal discharge, facial pressure and pain. You can have dental pain, but the key is something that's persistent. So something that is lasting more than 10 days or lasting a week and then worsening after a week. So that's kind of an acute sinusitis picture. But patients can also have a chronic picture where they have chronic facial pressure and just chronic simmering issues, and partnering with an ENT or a rhinologist or an ENT who specializes in sinus surgery would be very helpful for that. Children can have the same symptoms, but some of them are a little more subtle. You know, they can be persistent nasal drainage and congestion, persistent cough. It's really harder to differentiate in a child whether this is a sinusitis or just a rhinitis, just a nasal infection, because they're very well intermingled. And if things aren't responding to multiple courses of antibiotics, that's when a typical evaluation by an ENT or a pediatric ENT probably makes a lot of sense. So what are our options? What are our options to deal with sinusitis when we find this? I think the most important thing everybody with ectodermal dysplasia or recurrent sinusitis pictures could be doing is nasal irrigations, and then working to keep those crusts removed as best we can. The nasal crust removal may need to be involved with a professional as well, because they can be very hard and they can be rocks sometimes, but you can keep them from being hard and rocks with persistent nasal irrigations, and I'll kind of show you some of the options for that as well. Antibiotics, if it's an acute infection. Nasal steroid sprays can be useful to decrease inflammation in the nasal cavity, but you do have to be careful because they can also dry the nasal cavity. And again, we don't want to fight ourselves with dryness with more dryness. So there are nasal steroid sprays that are more moist, like Sensimist. It's an option that has a little more moisture and can be less drying on the nose. If there's an allergy component, having allergy treatment can be helpful. And then surgical options. If somebody has chronic sinus issues in the pediatric population, our typical first line therapy is taking out the adenoids. Adenoids are in the back of the nose, and they're what kind of blocks the back of the nose. For the adult population, a lot of times it involves more sinus-directed surgery and endoscopically opening those sinuses. But again, that doesn't fix the underlying problem. Sinus surgery allows you to more effectively use irrigations and preventive measures to wash things out when those cilia aren't doing that on their own, and to keep things moist when those mucus glands aren't doing that on their own. This is a good picture of a patient with nasal crusting. As you can see, it's just very tenacious crusting that you can grab with a pickup and actually pull out, and there can be infection that gets under that just because it gets trapped in this dry nose. And this dry nose also predisposes you to epistaxis and nosebleeds, which we'll talk about as well. This is what I frequently recommend for pediatric sinus irrigations. They make adult versions of this as well. Another version of it's called the neti pot. I like one you can actually squeeze and kind of wash things out. And you can't hurt yourself with this as long as you're using the salt packets and sterile water with that. I think that your nose is very tolerant of irrigations when it's saline solution that's with isotonic sterile water. There's a new kind of pediatric version of this coming out called the NoseBot, being designed by a pediatric ENT, which I don't have any affiliation with, but I know him well, and he's trying to create something that makes it easier for pediatric children, and this should be available pretty soon on the market. But keeping things moist is super important. If you don't keep things moist, you end up with nosebleeds, and nosebleeds can be very aggravating, which I'm sure many of you have experienced. So what can we do? What can we do to prevent those nosebleeds? One, nasal saline, lots and lots of nasal saline. But if you ever squirt a water bottle on the wall, you'll notice that nasal saline or that saltwater water just kind of pours down, right? And a lot of things will happen with saline like that. So what you can do instead is they make a lot of saline sprays that are sticky. So when you spray them, they stick on the wall and stick inside your nose and won't run down. And they'll last a couple hours. So when my children in the fall get nosebleeds in the winter or nosebleeds in the summer when it's hot, we will go back to these sprays and use them a couple times a day. And again, they're saltwater, very safe. You can't overdose somebody on a saltwater spray. Topical ointments can also be very helpful, especially before you go to bed. Vaseline or saline gels. I typically recommend saline gels. Vaseline's probably not a good long-term solution, nor is an antibiotic ointment, but saline gels that are like an ointment and can be put on a Q-tip and gently put in the septum, right here at the middle of the nose, can be very helpful. Cool mist humidifiers at night or a central humidifier in your house can also be very helpful. These are two of the common nasal sprays that I recommend to people. Again, unfortunately, no financial interest in these companies, but they are sticky and they spray really well and people seem to like them, and my children don't mind them either. So what do we do? What else can we do? We can avoid aspirin and ibuprofen. Something short-acting like ibuprofen and Tylenol is not so bad. Aspirin lasts 7 or 9 days, and unless it's being prescribed for a heart issue, I'd probably go with ibuprofen or Tylenol. heavy lifting or straining, and really just trying not to manipulate your nose and not take out those nasal crusts if they're dry. You know, any of those nasal rocks or rhino lifts, as you've probably heard, if you're going to try to take them out with a Q-tip or have somebody take them out, make sure you've used a lot of nasal saline and you've got them as moist as possible. That way you don't create a nosebleed when you remove them. But nosebleeds are going to happen. So what are you going to do? This is probably one of the more common things I see in my world, but I ask you to stay calm, breathe through your mouth, sit down, lean your body and your head slightly forward, but don't put your head between your legs. You don't have to bend all the way forward, and please don't lean back and let the blood pour straight into your lungs. A little bit forward, head down. Use a basin or a damp washcloth, but don't stuff the washcloth or the toilet paper in your nose. That's not helpful, and that's no fun when you come and I have to pull. One of the best stories in my world my mother told is having to pull an entire roll of toilet paper out of my nose when I was a child, hence why I'm an ENT. But what you do want to do is use bidigital nasal pressure, 2 fingers on the soft part of your nose for at least 10 minutes. And if it doesn't stop at 10 minutes, I want you to do it for another 10 minutes. No peeking. If you're peeking, you got to restart the clock. If you're not watching a clock when you're doing this, you'll never do it enough. You can use some Afrin or neosynephrine in your nose. You just got to be very judicious with how many days you use it for, because your nose can get addicted to it and have actually an opposite reaction. It can cause swelling in your nose, and you don't want to deal with that. So limit that for a couple days. If it bleeds more than 20 minutes, you probably need somebody to take a peek at that that's got a little more experience. And this is my dynamic nurse practitioner demonstrating how you need to hold your nose. And for 20 minutes, just like that, it should be firm pressure. It should be a little uncomfortable, but not terribly uncomfortable. If it's a child, a parent should hold the nose. Okay, we are going to move on to our oral manifestations. And I put these last because they, out of all the reading I've done on this, are some of the more frustrating issues people have. And unfortunately, some of the harder things for us to deal with, because we don't have just easy fixes, or like with epistaxis and with ear issues. Those issues I can address more easily. These are harder. Salivary glands tend to promote dryness to the mouth. Dryness to the mouth, that without that saliva, the amylase in saliva helps protect the teeth from dental caries. So super good dental hygiene is very important. Decreased taste and smell. As you guys know, difficulty swallowing, hoarse voice, and laryngitis. You know, I tried to identify, and you guys can probably educate me on this, about any kind of buccal or increased pigmentation around the gums inside the mouth. I couldn't really find any information out this, but it's been kind of mentioned in the past, especially by Charlie Meyer, who some of you guys might know, who trained me in Cincinnati. I think he was with the foundation back in the early 90s, and he trained me in Cincinnati, but he did not expand on that. So hopefully you guys can fill me in a little bit. So what can we do? Clearly the number one thing we can do is hydrate. Lots and lots of hydration. And patients always ask, what's enough hydration? And for my tonsillectomy patients after surgery, what I tell them is, if you pee and it doesn't look like mellow yellow, you're doing a good job. So that's a good idea. The more, you can drink as much as you can and keep yourself really well hydrated. Humidification at night, some of these nasal saline sprays and things can also hydrate the back of the throat and the back of the nose. Sialagogues, that's a fancy word for saying something sour. So a sugar-free lemon drop, just keep a bag of those on hand, and that'll help your submandibular glands and your parotid glands secrete saliva that might not have been affected by those small serous mucus glands that are present. So that can help with dental caries. Salivary replacements can be helpful for some patients. Dental hygiene and brushing, I think brushing every time you eat and making sure you clean any of that food debris out is very important for dental hygiene. Avoidance of irritants, smoking, chewing tobacco, vaping, anything that's going to kind of cause dryness or irritation in the mouth, in the voice box, the back of the throat, is to be recommended. Allergy management. Reflux, I didn't put that on here, but reflux can irritate the back of the throat and the voice box, and making sure that that's not a big issue. And that probably means things like not eating very late at night, increased alcohol, increased caffeine late in the day can increase reflux as well. these issues, a lot of these voice and swallowing issues need to be managed in partnership with a speech and swallowing specialist. And that can also be a specialist evaluation ENT. A lot of times those doctors are called laryngologists. They deal strictly with the voice box, and a lot of them also deal strictly with the swallowing, and partnering with them for swallowing therapy can be helpful. But a lot of this is going to be limiting or having smaller food boluses that are going to be washed down with more hydration, and things that are, there's not a magic fix, but I think working with people to kind of improve quality of life and have be able to kind of manage these symptoms can be done if you're partnering with somebody. Other oral manifestations, ectrodactyly, ectodermal dysplasia, cleft lip, and palate syndrome. You can have these issues for rare patients with ectodermal dysplasia where they have cleft lip in the palate, they have limb abnormalities, and ectodermal dysplasia. This is a soft palate cleft that can be visualized in the back of the mouth. This is a unilateral cleft palate, and this is a more extreme case where it's a bilateral lip and cleft palate. And as you can imagine, there's a varying degree of impact on the swallowing function in these patients and the speech function. This is a submucous cleft palate where the palate's intact except for the uvula. And these patients can go missed into late childhood, and their voice can be affected. The voice is the palate has to be able to move and touch the posterior aspect of the throat. So not only can patients be at risk from a hearing standpoint, but they can also be at risk from an anatomical standpoint in their palate and in the back of their mouth. So really having somebody that kind of has an idea of the multiple different manifestations that ectodermal dysplasia can take is important. That way, when you're managing their speech and their language acquisition, somebody knows kind of what to look for. And I think that's where I'll kind of leave it. I'm happy to answer questions. And again, I wanted to thank you guys for letting me talk today. And I don't claim to have all the answers, but I'm happy to partner and participate and try to find answers for you if I can.
Thank you very much, Dr. Hopkins. I want to remind everyone, let's see, let's stop sharing your screen. Perfect. Thank you. I want to remind everyone we are recording. We have two options that you can submit your questions to. We have about 15 minutes for a Q&A session. There is the chat function as well as the Q&A function. And so I'm going to start with the Q&A function, and I'll just read these questions to Dr. Hopkins and all of you, and then we will we'll let him answer them. What is your suggestion for tube placement if hearing is okay, yet water seen for about 6 months?
So what you're describing to me is what's called otitis media with effusion, but it would be chronic. So it's called chronic otitis media with effusion. And any effusion that's there for more than 3 months typically isn't going to go away on its own. If fluid's there, when fluid arrives, 1 month out, 90% of the time it goes away. At 2 months out, 95% of the time it goes away. And at 3 months out, if it's still there, it's probably stuck. And the problem with fluid behind the eardrum is the thickness of the fluid determines the hearing loss. So if it's thin and watery, you may not have any or very minimal hearing loss on a hearing test. But that can fluctuate on a day-to-day basis. And when it gets kind of thicker, that's when the hearing can drop drastically. And I would say if you have two options. Either you place tubes and get that fluid out and then live to fight another day when the tubes fall out, or you follow very closely with an otolaryngologist with hearing tests every 3 months to make sure the hearing truly isn't impacted.
Okay, great. Someone else has asked, should their 22-year-old son get deviated septum surgery, and how beneficial might that be? I think I know this family, and if it's a family I'm thinking about, I believe they're affected by hypohidrotic ectodermal dysplasia, if that helps. I don't know if that would be a difference for syndrome?
I think the question is, what are your goals? What are you trying to accomplish with septoplasty surgery? So septoplasty surgery, there's the main role in that is increasing nasal airflow. So if you're having nasal obstruction due to the deviated septum, then I think that's a reasonable option. Fixing a septum itself will not change the external appearance of the nose. That would have to be in concert with a open septum and rhinoplasty surgery. But a lot of times you combine a septoplasty with that when you're addressing the external nose. But if there's nasal obstruction, then definitely a septoplasty at that age is a very reasonable option.
Okay. Our next question, her son says it burns or stings when they irrigate the nose with saline. Is that normal?
It can. So sometimes that can be the case. One of the things that some people find better is if the water's a little, it's right at lukewarm to warm. So when it's cold, a lot of times it stings more than if it's a little more warm. And then if it stings and it's a big issue, I think that tinkering with the amount of salt in the water a little bit is not a crazy idea. You can add a little bit more of the salt packet, and sometimes that can take the edge off and sometimes it may be a little less. So I think you can go back and forth just a little bit with the amount of volume of salt you mix with the water, because that can affect burning. Same as if you jump in a pool and you suck in water in your nose, it's going to burn. That's because there's no salt in it. When you mix that, when the saline packets neutralize that, but it may be that it's not perfect for your son.
Okay, thank you. That's a good question and helpful. I gained so much knowledge to be able to help our families these days. So as you probably saw me taking notes over here while you were speaking even. So we have another mom that's asking, is there a tool that parents can use at home to remove earwax? Sometimes
I wish.
Wax that I might remove and don't dare to stick anything inside his ear, but his appointments to wax removals 3 to 4 months out.
That's a great question. I think that everybody's wax is very different. So some people's wax is very dry, and if it's just kind of at the right opening, that wax can easily be flicked out with a little Q-tip or something like that. But I think the problem is a lot of patients have sticky wax, and if you try to get that out, all it does is push it in further. So what I would do is the next time you're in with your ear, nose, and throat physician, one, it's probably not unreasonable to start some Vosol drops a couple days prior to seeing them, and then asking, with this kind of wax that my child has, is it okay for me to grab that wax? And I think being very actively participating during the exam of your child to see exactly what the physician's doing. Most physicians are going to be very amenable to teaching you some of the easy things that you can do. If you're saying, hey, can I get this next time you're in the office? And they're going to tell you yes or no, and then they'll let you know if that's safe or not. But I wouldn't dare say grab it without at least looking at your child once.
Great. So another family's question is their 4-year-old who has HED, has very small nostrils, and they have a hard time getting the crust out, even with irrigation. What can we do to help? And they did not have an issue with this with their son who's older, who's now 18.
Yeah, that's super frustrating. The key to this is going to be trying to not let it become a hard crust. So the more you can do with nasal saline gels or with saline ointments where you put a Q-tip and just gently roll it again, people get dry in the middle, so not on the edges. So when you put a Q-tip in and you roll it on the septum is the best way to put it in. And when you put it in, you only want to put the white part of a Q-tip in the nose. So just a little bit of a Q-tip with some ointment on it, some saline gel or Vaseline gel. And doing that, if it's saline, you can use it 2 or 3 times a day. I wouldn't do that with Vaseline. If you're going to use Vaseline, maybe once at night, and then save the saline gel or saline gel sprays for the day. But yeah, clearly a very frustrating issue in kids with small noses. So It's a difficult problem.
Yes. Is it safe to use the Navage? Is that a brand? Nose cleaner when there are big rocks in the nose and their son is affected by HED.
Navage. How do they spell it?
They have it spelled Navage.
Hey,
No.
let me, I don't know it offhand. Let me take a peek at it here.
Okay.
Navage nose cleaner. Yeah, so the Navage nose cleaner is probably no different than that nose bot that I showed you. It really is just a automated mechanical way of using a sign your rinse squeezy bottle. So I don't have any objection to that as long as they tolerate it well. It's the same idea as a saline rinse or a nose bot. So as long as you're using saline with salt, with the little packets that to mix up the saline, I think that would be very safe.
Okay. My 12-year-old has had 3 sets of tubes and went in for another set. Recurrent infections that are difficult to clear, but there was too much scar tissue. He continues to get infections, especially in summer with swimming. He wears earplugs with swimming. Beyond that, any suggestions? And I think he's affected by EE, I think.
Sorry, I missed that, Kelly. One more time.
I was going to say, I think he's affected by EEC, I think.
Okay. So, it definitely can be frustrating once you get to the point where you're needing to place multiple sets of tubes. So the issues you're talking about are 2 kind of separate issues, because the ear infections with water are kind of one problem, and that can be managed with your ENT by, when tubes are in place, if you're getting infections with water, managing that with watertight earplugs. And a lot of times that can be made by an audiologist. They'll make a mold of your ear canal, and those molds can then be watertight. Over-the-counter ones, there's some ones called Pro Plugs, PRO-plug, and you can get them on Amazon, and they have different sizes of them. They're semi-occlusive to water. So I typically start out, when my ear tube patients have issues with water, I'll start out with the Pro Plugs, and if those aren't perfect watertight, we'll have an audiology mold made of them in the ear. The difference is an ear mold probably costs about $100 as opposed to the Pro Plugs, which are about $15. So most patients can deal with the Pro Plugs. Now, the question of needing ear tubes is a different question. If you're still getting recurrent ear infections that are not resolving and you're still needing tubes, that becomes harder. And you can't have a longer ear tube placed, a more permanent tube that lasts a long time. But once eardrums start scarring, it becomes a lot harder. So we'd have to know a little bit more before I'd kind of weigh in more than that.
Absolutely. What do you recommend for softening earwax? Could you go over that again?
Sure. With ear tubes in, I don't recommend patients use anything except the antibiotic ear drops that most pediatric ENTs or ENTs send you home with, the Floxin drops or ofloxacin drops. Those are antibiotic prescribed ear drops, but most families with ear tubes will know what I'm talking about because we send them home with them all the time. If you don't have ear tubes, then the options for softening wax are 2, either hydrogen peroxide, half-strength hydrogen peroxide, or half-strength white vinegar. And I prefer the half-strength white vinegar solution, which is over-the-counter. It's called Vosol. But you can make it with white vinegar and sterile water, half and half, and that works well too. But the over-the-counter Vosol is very affordable. It comes in a little bottle. You can soften the wax up. But it doesn't get rid of the wax is the problem. It softens it. And if it's just a very minimal amount, maybe it dissolves a little bit of away. But if it's a big firm plug of wax, that's probably more useful to soften the wax and then have somebody who has the expertise to remove it help you remove it.
Okay. Let's see.
Ear candles don't work. Don't put anything in your ear smaller than your elbow. That's usually our recommendation.
That's right. That's right. I can hear my grandmother's voice telling me that actually. So that recommendation goes a long way back.
Yeah.
And she was not an ENT.
She may have been the first.
Yeah, right? So someone's son uses headsets for long periods of time. Are there any concerns with using the use of headsets in relationship to hearing or hearing loss?
I think you have to be careful with volume on headphones in children. They have a tendency to want to turn things very loud. So for most kids, I think over the ear headphones, or at least little kids over under age 10 or 12, over the ear headphones are probably going to be the better option. In the ear, like earbuds, are probably safe as well, unless it's pushing that wax in, and you got to be careful with that. So I think it's a case-by-case basis. Again, they make a lot of new bone conduction hearing aid options, or not just hearing aid, but bone conduction headphone options that are really great because they bypass the external ear canal completely and work really well.
I never thought about that, about the in the ear pushing the wax. I'm glad you said that. Why is there a false smell when they have those hard nasal rocks? What causes that smell?
Yeah, it's the secretions that build up underneath them, and they just get kind of fetid and gross. It's just that those secretions are, I wouldn't say necessarily infected, but the same as if you left a wet sock in the dryer for a couple days, it would kind of have an odor to it, the smell. And once those nasal crusts come out and that is open to air, that would go away.
Okay.
But you have to get the crust out.
We have a lot of questions yet on the Q&A or comments, but I'm going to flip over to the chat section for just a minute because I feel like I've neglected all of you that have used that option. Let's see. Could you elaborate on the potential risks of turbinate reduction surgery? And did I butcher that?
Yeah. No. I think inferior turbinate reduction surgery is very similar to a septoplasty in the fact that its goal is typically to give you more room inside your nose. Turbinates sit on the sides of both of your nose. The septum sits in the middle. So when you do a turbinate reduction, you shrink those shelves down to provide more runway for airflow to go through. And I think the goal of that is either to increase airflow or to increase the ability to irrigate and to perform pulmonary or nasal hygiene.
Okay, let's see.
But safe, if the question was safe, then yes, I think it is safe.
Okay. Can you, again, some more names that I'm not familiar with. Can you comment on, was it Vasal versus Ceramionetics, eardrops versus D-Brox? And sorry if I butchered that, but you probably know what I'm trying to say.
Yeah, I don't know one of the brands they talked about, but D-Brox, I believe D-Brox and Vozol are both acetic acid vinegar solutions. And I wouldn't say one's more magical than the other. They just slapped a brand name on white vinegar, half-strength white vinegar.
Okay. Well, perfect. Easy enough. Okay, so we do have some comments, and I'll go ahead and read. Someone thanked you for covering hair loss and stressing the importance of hearing screenings. I'm a huge fan of the newborn hearing screening, as her son was identified to have a profound hearing loss at 1 month old. So hearing screenings are very important. So thank you for covering that. We have someone that's an audiologist and a parent of a son with HED, and they found that mineral oil helps with dry or flaky wax. So just some parental response to confirm what you've shared with us already.
Yeah, I love mineral oil. You just got to be cautious about using too much, because if you pour it in there like a bucket and then it's just floating in there, it can cause muffled hearing. So just partner with somebody when you figure out how much to use, and just don't overdo it, I guess, is the question, or is the recommendation.
And did we already discuss this? How many turbinate reductions can you safely have done? Did we discuss that already?
That's a great question. No, we didn't discuss how many you have done. The ones that are reduced are the bottom shelves. There's 3 sets, but the bottom's one's the only one we typically reduce. There's some techniques that can have a little regrowth, and then you have to do it again. So a little bit of it's the type of technique somebody uses. But typically, I wouldn't say it's done more than twice, because usually if you've done it once, the second time you're going to be more aggressive and keep from doing it third time.
Okay. We have time for just one last question before we sign off for the evening. Someone their son has a problem with loud noises. Is there anything that they can do to help him with that?
Yeah, that's a great question. I think that it, and we have an audiologist on the line. They may be able to help me with this, but to my knowledge, there's no such thing as being able to hear too well. So it's not a problem with the volume. I do think a hearing test is appropriate, and an evaluation by an audiologist and ENT is a good idea for that patient. But typically, a lot of these issues are processing issues. So they're getting the sound, and their brain doesn't know what to do with it. So it makes them uncomfortable. And that can be seen with lots of children with sensory processing issues, not distinctive to ectodermal dysplasia, but I see kids with sensory processing issues all the time, whether that's loud noises, bright lights, too many people. That's just too much information for their brain. So a pediatrician and a speech pathologist, sometimes a behavioral psychology or developmental pediatrics can help identify, is there a particular technique we can do to teach those children processing skills or techniques that can kind of redirect that sound and make it tolerable for them. But I don't recommend like putting headphones or earmuffs on children to make sounds less for most kids. I think that can be kind of feed the cycle. That's not a good idea.
Okay. Well, thank you very much. We have just a couple more questions, and I think we'll filter those through email. And we'll get back to you. I have access to all of that information behind the scenes. So we will get your questions answered sometime over the next week or two. Just please be patient with us as all we ask. We thank you so much, everyone, for joining us tonight for this edition of Conference from Your Couch. And Dr. Hopkins, thank you very much for speaking with us tonight and sharing your knowledge with us. I know I speak for all of our families and our staff, and you're very much appreciated. And we know this took time away from your family this evening, so please extend our thanks to them and let them know we're grateful as well.
Thank you, guys. Have a good evening.
Thanks. You as well. Night, everyone.